Hello, everyone. My name is Xinying Li. I'm a medical oncologist at MD Anderson Cancer Center here in Houston, Texas. Today, I'm joined by two of my colleagues, Dr. Christine Argento, who is an interventional pulmonologist at Johns Hopkins, and Professor Albrecht Stenzinger, who is a molecular pathologist at University Hospital Heidelberg, Germany. In today's section, we'll be discussing a case with MET amplification in EGFR-TKI refractory disease. Here is my clinic. I had a patient who had been seeing for actually a couple of years. This is a 77-year-old male who had a prior smoking history. About 2 years ago, the patient was diagnosed with stage 4 lung cancer. At that time, we detected EGFR deletion 19. Therefore, the patient received upfront osimertinib for about 2 years. In the recent interval, basically in the last 2 to 3 months, the patient started to notice increasing coughing and some shortness of breath. At the time of restaging scan, we did detect that the primary tumor started to enlarge, as well as associated mediastinal lymph nodes and hilar lymph nodes. In this particular patient, by the CT scan, the tumor size has enlarged to about 20%. Therefore, I had a discussion with the patient of potentially disease progression. One part that's important for managing TKI refractory EGFR mutation non-small cell lung cancer is to understand if there is a secondary genetic driver, because we potentially have newer medication and the combinations to help this patient population. If the tumor has no genetic driver, the patient's resistant driver, then the patient's next option will be chemotherapy-based or other investigational trials. To understand the molecular resistant driver, I send off the liquid biopsy. That's a relatively very non-invasive approach. However, I do also want to obtain tissue. One reason is to rule out small cell transformation and the squamous transformation. The other is to have the tissue for a tissue-based NGS testing. Today in my clinic, I want to discuss this case with my interventional pulmonologist team to see the feasibility and the safety of a EBUS potentially for this patient. Therefore, I walk over to Dr. Argento. Dr. Argento, for this case, can you please review with us about the potential pros and cons of different tissue acquisition modalities? And for this particular case, do you have your recommendation?
Yeah, thank you. I think this patient, for me, is a pretty clear pathway towards endobronchial ultrasound or EBUS, because not only has the primary tumor enlarged, but so have all the associated lymph nodes in the chest. So EBUS is really an extremely safe, quick, easy way to obtain tissue that is going to be really good to look and see, has there been any transformation as far as the histopathology of the tumor, as well as to obtain additional molecular markers so that you can send off NGS testing and make sure that there are no driver mutations that are affecting this progression of disease. And so I think the one good thing in this case is that EBUS is repeatable. So you can do EBUS over and over again as needed as these patients progress and they wax and wane. Sometimes when they're on therapy, their lymph nodes and even their primary tumors can enlarge, and then they can eventually recede depending on how things are going. But often this does need, unfortunately, means that there is progression of disease. So I think the biopsies are, generally speaking, very high yield, even in patients who have been on therapy for several years. Even if they've had other things like radiation therapy, for example, may cause some fibrosis of the lymph nodes or of the primary tumor, which may cause the sample to be a little bit less cellular than it would have been originally with biopsy. But if we have our cytopathologist or pathology colleagues in the room with us. That's called rapid on-site evaluation, or ROSE. They can often let us know, give us feedback on our sampling in the procedure to make sure that we have enough cellularity to do all the testing that we need. And that makes sure that our bronchoscopy is going to be a one and done. So your patient doesn't have to come back for multiple procedures, multiple forms of biopsy. You should be able to get all of the tissue you need for all of the testing you require in one setting.
Thank you. Thank you very much. So in this case, since you strongly recommend the EBUS, I also felt that's a procedure that we perform a lot in the high volume centers. So the patient proceed with EBUS biopsy, and his tissue, of course, detected malignant cells and were sent to the core for additional testing. So here, I want to hand this case over to our molecular pathologist, Dr. Stenzinger. So as a clinician, I would like to know, first of all, how quickly I will know the histology report and how quickly I will have the NGS if there's no transformation so that I can make clinical decision. Of course, what type of testing you will apply for this particular case.
Yeah, thank you. I mean, the turnaround time for rendering an initial diagnosis, this case, non-small cell lung cancer, adenocarcinoma of the lung, that is usually a turnaround time, depending on the lab, between 24 and maybe 48 hours. Some institutions may be even faster. With respect to the molecular testing, a combinatorial approach using liquid biopsy and tissue-based testing, could make sense. For tissue-based testing, RNA and DNA sequencing is very much needed. Simply because on the DNA level, since most of the assays that are being used are panels, intronic regions might not be well covered. And so breakpoints, that give rise to fusions might not be adequately covered as well. And the RNA side would give you the fusion transcript, so that can help quite significantly. Depending on your setup, you can also detect, high-level amplifications very nicely using a panel-based next-generation sequencing approach. On the liquid biopsy side, things are a little bit more tricky. Remember that, RNA-based sequencing from blood is not something that is routinely used in daily clinical care. So most of the panels out there are on the DNA side, and then you really want to make sure that your DNA regions, including those for the big breakpoints of gene fusions, that these regions are really well covered. Also, there are differences in terms of shedding of tumors. Different tumor types shed differently, and also depending on the tumor stage. And that very much influences your, sensitivity and specificity issues. Last point for liquid biopsy, you really need deep sequencing. So in Heidelberg, we run these with 10,000x over locus, as compared to maybe 300x when it comes to tissue. The reason being that sometimes the amounts of positive molecules, those with a lesion, can be really small. And very last point, molecules that aren't there cannot be sequenced. So it's very much influenced really by the shedding aspect and the number of molecules that you detect in your cfDNA.
Yeah, thank you for the detailed explanation. So based on your guidance, we send out for both RNA and the DNA-based sequencing. And like you said, 1 day later, we know that these patients still have adenocarcinoma, no transformation. And about 1 week later, we received liquid biopsy results. We still detected EGFR deletion 19 truncal deletion mutation, but didn't have any additional alterations in the liquid biopsy. At this time, I turn to you, of course, sending emails asking when the tissue results going to be back. In this particular case, will you recommend us to wait? Clinically, the patient is quite stable, although have some coughing, but it's been going on for more just at the baseline and a slow progression disease. So do you think there's still additional value to wait based on the no transformation, based on relatively no driver mutation detected in the peripheral blood?
Thank you. I mean, that, refers back to what we discussed before, a question of molecules that aren't there, cannot be sequenced, right? And so it can well be that in a liquid biopsy specimen, some event goes undetected because the molecules harboring a certain genetic lesions are simply not present or not present in the amount that is needed in terms of your assay sensitivity. So having both, the tissue-based data and the liquid data can be very helpful. And as you say, if the patient is stable and we have some more time, I would recommend doing so.
Yeah. Thank you so much. So we, as a team, decided to wait. Of course, patient is a part of the decision-making team for the complete tissue NGS report to return before we make next step clinical decision. Another week passed by, we did receive the report from our molecular pathologist team that the tumor has MET amplification at very high copy number greater than 10. So in this particular case, we identified a resistant driver for this EGFR TKI refractory tumor, and therefore we start to think about downstream. The treatment option can be dual inhibition of EGFR and the MET pathway. So in this particular case, the patient end up going on to a double TKI inhibition. But I think for this discussion, we just highlighted the importance of trying to understand the resistance mechanism. We will give our tradition. I will turn to our colleagues today just to give us one-liner summary about in this TKI refractory situation, no longer newly diagnosed, what's your advice for physicians and the patients? So I'll start again with Dr. Argento, our interventional pulmonologist.
Thank you. I think in this case, it really highlights well the importance of making sure to really investigate what's happening in these patients and do that with an additional biopsy to make sure they haven't transformed, and to be able to look at your NGS panel for additional driver mutations that will be able to help and guide treatment. From my standpoint, EBIS is extremely safe. It's able to be repeated time and time again. So whenever the patient needs additional tissue, this is a really good option that is effective whether the patient has been on therapy already or not.
Thank you. And Dr. Stensinger, please.
Given the heterogeneity of any solid cancer and non-small cell lung cancer as well, combinatorial approaches in terms of testing can make a lot of sense, as we've seen here. Combined sequencing of the tissue, most recent tissue plus a liquid biopsy can be very important. The one point that I'd like to point out again is really that molecules that aren't there cannot be sequenced, and so even though liquid biopsy technologies can be super sensitive, they are very much influenced by the number of molecules per locus that you are detecting, and that is simply important to keep in mind. In other words, there can be false negative results, even though a genetic lesion is biologically present and also druggable, and therefore the combined view, including the tissue side, can make a lot of sense.
Yeah, thank you very much. I think that concludes our day. Thank you for your attention. Hello, everyone. My name is Shiming Li. I'm a thoracic medical oncologist at MD Anderson Cancer Center here in Houston, Texas. Today, I'm joined by Ms. Stephanie McDonald. She is an oncology nurse practitioner at the Dana-Farber Cancer Institution in Boston. And we also have Dr. Sandra Kuller, a clinical oncology pharmacist at the University of Illinois, Chicago. In today's section, we'll be talking about MET targeting strategy for EGFR mutation non-small cell lung cancer patients who are refractory to EGFR TKI. We will start with a patient case. Today in the clinic, we have another patient come back for routine follow-up. This is a 77-year-old male. He is a former smoker. He has been in my clinic for about 2 years. At the very beginning of the diagnosis, there was a 5-centimeter lung mass identified, and the biopsy showed adenocarcinoma. At that time, he had distant metastasis, and the DNA testing indicates an EGFR exon 19 deletion. He has been seeing me for about 2 years because he was placed on osimertinib for the whole duration. He had a very good response initially. However, in the last couple of months, he started to have progression both in the primary location as well as in the metastatic site. Because of that, we performed a CT scan. We also performed the biopsy to understand what is the resistance mechanism to the EGFR TKI. Today, he's back to the clinic because our NGS testing is returned. In my last clinical discussion, we talked a little bit about potentially start him on chemotherapy, carboplatin with pemetrexed as a standard of care if there's no driver detected to correlate with resistance. Today, when I sit down with the patient, we did have the biopsy report showing a MET amplification, very high copy number at 10 copy number. Therefore, I first have my discussion with my team before I approach the patient. Here, I talked to our clinical pharmacy team, Dr. Sandra Puri, about the copy number MET amplification at 10. Sandra, can you deliberate on some of the options this patient might have with this new biomarker detected resistance?
Yeah, thank you. Absolutely. And as you know, Dr. Lee, when we send these next generation reports, sequencing reports, it's like we're on pins and needles, right? Because it takes about 2 weeks to get this result. And we're hoping that there is a targetable mutation. And especially in the second line setting, sometimes that there isn't anything, we have to go straight to chemo. But fortunate for this patient, we did detect, or there was a detection of MET amplification. So here, again, our options are, now we have more options than just systemic chemotherapy. We have amivantamab, which is a dual bispecific systemic treatment. And we also have data where we can maybe add tepotinib, which does have data with MET amplification in combination with an oral EGFR agent. So I think here we have two options. We can do oral, targeting both mutations, or we can do it IV, systemic with amivantamab. So I would like to see what are your thoughts on which direction we would go to, again, knowing that this patient is 77 years old, previously on oral therapy. What are your thoughts, Dr. Lee?
I think I probably prefer oral, and then not just because it's dual targeting, but I think it's also for the convenience of the patients. So Sandra, tepotinib, do we have once a day dosing? So if that's the case, patient can just simply add a pill to the OC, right?
Yeah, so tepotinib would be two tablets, 450 milligrams once daily with food. So that would be something, that we could add to the osimertinib, with multidisciplinary team of a nurse practitioner, specialty pharmacy, clinical pharmacist, really sitting down with this patient, making sure that adding a oral agent to his medication treatment plan would be something that this patient would be able to do, along with treatment diaries, pill reminders, that this is something that hopefully would be easy for the patient to do.
That sounds actually very appealing, because if we have to go, so two reasons. One is after progression of dual oral medication, we still have the opportunity for the patient to receive IV treatment. The other will be simply adding a pill will maximally preserve the quality of life for this particular patient. Of course, when all of us are sitting in the physician room, Stephanie, I will have to rely on you to manage the dual TKI toxicity.
Yes, I think it is a all hands on deck approach, especially when you're adding two separate oral medications, because although the efficacy might be higher, the toxicity profile is higher as well and more extensive, especially knowing the mechanism of action for each of these drugs when given in combination. We definitely have a lot to educate the patient about and a lot to monitor to safely provide excellent care for this patient as they're on this journey. So I'll bring this patient into my clinic and provide education in a one-to-one session, introduce them to the role of our nurse navigator so that they can communicate when issues arise, and really hone in on the importance of calling us early, not waiting until maybe some symptoms are out of control or they're really not feeling well, to really kind of lean on us, know when to call at the first sign of maybe a potential side effect. So when you're giving these two drugs in combinations, you have to be monitoring for the EGFR potential side effects and the MET inhibitor side effects. So when they're coming into my clinic for monitoring, we're going to be checking baseline labs and monitoring for QT. You can have QT prolongation from the osimertinib, and so we want to be monitoring that at baseline and periodically throughout treatment. So usually I'll get that at their first visit, and then about 4 weeks later, and sometimes 2 weeks later, or depending on their history, how frequent you're getting it. Monitoring their kidney function is very important in these scenarios, as well as electrolytes that could be altered throughout the course of treatment. I would say, as far as education, if they've been on osimertinib already, they're probably well-versed, but just reinforcing the importance of calling with, rash or new shortness of breath, new chest pain or shortness of breath, the importance of management for diarrhea, especially on these treatments, and calling for any fevers or infectious complaints. And then again, honing in on the importance for the tepotinib portion of the drug, which can cause the edema and swelling. So again, just educating them on elevating their legs. We can utilize compression stockings, but first it's important for them to review and rule out other causes of leg swelling. So making sure they don't have a blood clot or an infection like cellulitis causing the leg swelling. So I think, again, it gets to the importance of a multidisciplinary approach, utilizing our physical therapy team, our pharmacy team, our dietitian team, and really educating the patient on calling us for any potential side effects throughout their journey, so we can just be on top of identifying and managing any potential side effects that they have, so that they can safely continue on such an effective treatment.
Yeah, so with this conversation with my team, both with my PharmD as well as with my nursing team, I feel very comfortable and supported to talk to the patient about the dual TKI as our preferred regimen. From the INSIGHT-2 trial, we learned that osimertinib together with tepotinib can render a response as high as 50% and progression-free survival 6 to 8 months, depending on the copy numbers. So that I feel very comfortable starting with this patient. As a physician, I do want to highlight that in the EGFR TKI refractory space, we have seen a wave of clinical trials having very promising readout, potentially can change our landscape even further. For example, we start to see MET targeting ADC to have good efficacy. We also start to see EGFR refractory patient chemo in combination with PD-1 and VEGF inhibition also have very good efficacy in prolonging PFS. And the HER3 targeted ADC is also very promising. One last thing I want to add is for the biomarker, we no longer just think about next generation sequencing. We also start to think about cell surface. So IHC based for this particular case, I will ask my team to order the MET IHC in preparation for the next line of treatment. So as our routine, I do want to ask my team to have one line of highlight for this particular clinical case. Sandra, please go ahead.
Yeah, so I think that the take-home message here is, 2 oral agents targeting 2 different driver mutations has been investigated and demonstrated to show both safety and efficacy. Making sure we talk to the patient about the unique side effect profiles of each individual drug, and dose reductions would depend primarily on which adverse event the patient is experiencing. But this is something that is doable and is convenient for the patient.
Yeah, I agree wholeheartedly. I think the key to this, pursuing this dual treatment, is communication and education, and making sure the patient has the resources that they need to be able to safely continue on treatment. And if symptoms come up, they know how to get a hold of us, and we're checking in with them frequently, not only maybe by phone, but regularly, maybe every 2 weeks, especially as they get started on these drugs, to make sure that it's safe. And then we're balancing the efficacy of treatment and their quality of life, and making sure they have all their resources in place to help set up for success and to support them along their journey.
Yeah, I just want to say the precision oncology is moved forward such that we can do dual targeting, not just the primary TKI, but also adding a secondary TKI in a safe and effective manner. And going forward, we'll have more options for this patient population. Thank you for your attention.